and today it is a quiz for CXR ECG. So I will tell you in brief for one slide and then we will start the quiz. Okay. So for chest X-ray, please remember some of the important points. That chest X-ray can be classical, like agon side picture for TGA or boot-shaped heart in the tetralogy of Fellow. So it can be classical couple of times, what we can say book picture, but it may not be so in all the cases. So we have to be judicious in assessing case, clinical history, and relevant clinical examination, and on that background we can evaluate the chest X-ray. Sometimes it can be misleading might as well, and we all are aware. Describe the findings and not jump to the diagnosis whenever you see the X-ray. And we all should know A, B, C, D, T of chest X-ray, that is airway, bones, cardia, diaphragms and thymus. And most importantly, look here, look there and look everywhere. So you can, find out the problems. So let us begin the quiz. So what is this? Can anyone describe or tell the findings? You can type it in the chat box. It's not exam, so you can, attempt. There is no marks attached to the quiz. Kavita? Cardiomegaly? Okay. So fine. There is no cardiomegaly, normal cardiothoracic ratio, but we can see that apex is slightly, rounded. So there is a probability of RV enlargement. However, cardiothoracic ratio is normal and there is a pulmonary plethora. So this patient had a large ASD. So that's why we could see RV enlargement and pulmonary plethora. Same way, whenever there is LV enlargement, there can be cardiothoracic ratio completely normal. We all must know the one fact that LV can enlarge posteriorly. So in a patient with a frank LV enlargement can have normal chest X-ray frontal view because of LV enlarging posteriorly, and it is seen in lateral X-ray. So these are some of the exceptions. Okay, what is the finding here? Please type, don't hesitate. Keep on typing, not a problem. Anybody? This is a quiz, come on guys. Okay, I will give you some clues. Can anyone describe about the liver? Okay, huge cardiomegaly, okay. It can be thymus as well, especially if you see the right-sided superior border of the heart. It is thin, and this right superior border of the mediastinum has a different opacity as compared to the cardia. So this suggests that probably this is a thymic shadow, but yes, it can be still cardiomegaly. There is a midline lever that is very important, and you can also see that there is a upturned apex, most importantly upturned apex, and there is some, yeah, correct, so that is RV type of apex. You are right, Yasser Bhatt, Mahendra Singh, both of you are right. And there is, what about pulmonary vascularity? Please type Yasser Bhatt. Oligamia, very good, very good. Who said plethora? Mahendra, this is not plethora. I'm just speaking out your names, not to criticize anybody, but just to, make this conversation more lively. Mahendra, Yasser, anybody please opine on this chest X-ray? No need of diagnosis, very good. You can just describe the findings. Dextrocardia, correct. Dextrocardia, fine. What about the pulmonary vascularity? Center, okay, plethora, very good. Liver also appears central. We can't see the stomach bubbles, so most likely, a kind of heterotoxic syndrome. Yeah, everybody agrees on plethora. So this is the patient who has a heterotoxic syndrome with dextrocardia with a lesion in the heart, which is causing increased pulmonary blood flow. Correct. Very good. All of you are correct. Dr. Bhattacharya is also right. Okay. So now this X-ray, please describe the findings. First, you remember, airway is no problem, then bones, no problem, then heart. Cardia, pulmonary vascularity is part of the heart. So whenever you describe the X-ray, heart and lungs, okay, very good. Oligemia. What else? What about the heart? No cardiomegaly. There is a cardiomegaly because we have to, we have to measure the cardiothoracic ratio. It was a case of severe pulmonary hypertension, wherein because of the severe PH, there is a peripheral ballooning, but this because of poor quality of X-ray film. Even if you write oligemia, it's fine. But most importantly, you notice the prominent pulmonary knuckle. Okay, so please. You can write the diagnosis, you can write the findings for this X-ray, please. Dr. Sudipta, TOC is absent pulmonary valve, not a correct diagnosis, no. It can be, it is slightly looking like that, but it's not that, because in TOC absent pulmonary valve, these dilated pulmonary arteries are slightly lower side as compared to this X-ray, and they are towards the lungs. Yeah, so Yasser Bhatt, Mahendra Singh, both of you are right. Yasser has written complete diagnosis, supracardiac TAPVC. So it's a snowman sign or figure of 8 appearance, which is only possible after 5 years of age, because the structures of the pulmonary venous drainage pathway requires time to dilate. So if a newborn with supracardiac TAPVC or infant, you will never find this kind of X-ray. So can anybody describe the findings? What is the left superior border made up of? What is this shadow? You can see my cursor? Yeah, left-sided ascending vertical vein, correct. So Bhattacharya and Dr. Mahendra, both of them are participating actively. Then right superior border is made up of what? SVC. Yeah. Whenever we describe in heart, we all are pediatric cardiologists, you have to be specific. You should say dilated right-sided SVC. All of you are right. And what about the lungs? Plethora, yeah. And in case of TAPVC, it is because of pulmonary venous congestion. Fine. And there is also right atrial enlargement and right ventricular enlargement. So what is this finding? Anybody? No cardiomegaly. Okay. What is the type of the apex? See, we can be wrong also. RV type, correct. Dr. Yasser Bhatt is right. And there is a plethora, right? What about the pulmonary knuckle? It's prominent pulmonary knuckle. Okay. So prominent pulmonary knuckle, pulmonary plethora, yeah, correct. And RV type of apex. This was a case of TAPVC. Sorry. So friends, most importantly, that X-rays may be classical but may not be classical. So we have to describe the findings, and all of you were right. Findings. Quick guys, because we have ECG quiz as well. Cardiomegaly, what type of LV apex, right? All of you are right. What about the lungs? Plethora, okay? Any problem? So it's cardiomegaly, LV apex, pulmonary plethora. What about the pulmonary knuckle? Very good. So what is the probable diagnosis? Very good. This is the way we should write. Post-tricuspid shunt. Significant post-tricuspid shunt is the right answer, which can be, large VSD or PDA or even AP window. What about this X-ray? Same, almost, similar kind of thing. Only thing is peripheral pulmonary vascularity doesn't appear so prominent. So both of these X-rays were of a patient with large VSD. What about this? Any abnormal finding, please write. Dilated NPA, very good. What are the causes of dilated NPA? Pruning, not really. So guys, these are the causes of dilated pulmonary knuckle. One, it can be post-stenotic dilatation of valvular pulmonary stenosis of a classical variety. It can be pulmonary hypertension, or it can be idiopathic dilatation of PA. So in a previous X-ray, both this possibility 1 and 3 are correct. It can be post-stenotic dilatation of PH, or it can be IDPA, idiopathic dilatation of PA. Because in PH, we see some abnormality in vascularity. So what is this chest X-ray? Findings. RV apex, right? Right aortic arch, excellent, Dr. Mahendra Singh. Then, anything else? No cardiomegaly. What about pulmonary knuckle? Top, right. So Dr. Bhattacharya has guessed it, right? It was a case of tetralogy of fellow with right aortic arch. What is this? Findings, please. Cardiomegaly, huge cardiomegaly, right? Dilated RA, yes, we can say. Anyway, it's showing, dilated heart, probably a kind of globular enlargement of cardiac shadow, which can be, what are the Epstein's, can be yes. What about the lungs? There is some prominence of right-sided central hilum, which can be plethora, which can be pneumonia, it can be anything, because we can see peripheral vasculitis is not that prominent as compared to central. So what are the differential diagnoses? Pericardial effusion, right. Dr. Bhatt has guessed it right. It was a case of massive pericardial effusion. Okay, this X-ray please. Findings or diagnosis. Anyone? Hugely dilated RA, right? Epstein's, again, right? Dr. Yasser Bhatt, Dr. Mahendra Singh, congratulations, both of you are actively participating, giving nice answers. Very good. So it was a case of Epstein's. But whenever we see X-ray like this, remember important 3-4 differential diagnoses. One is Epstein anomaly, another is pericardial effusion. Then multivalvular heart disease also can give rise to such a heart shadow. However, pulmonary vascularity will be different in case of multivalvular heart disease. But whenever you see such a dilated heart and relatively oligemic lung fields, the first diagnosis is Epstein's. So this already I have discussed all 3 possibilities. Okay, so here findings, or if somebody can write the diagnosis also, I don't mind. Cardiomegaly, right. Okay, I will give you a clue. What about the base of the heart? Very good. Narrow pedicle leg on side. Right. So what is the diagnosis, Mahendra? TGA, correct. So remember, TGA gives you the TGA is always associated with pulmonary plethora when there is absence of pulmonary stenosis. Okay, diagnosis, newborn on ventilator, you can see some lines, RT, tube, central venous catheter. Diagnosis please. No cardiomegaly, okay. And rather than you saying no cardiomegaly, you can say normal cardiothoracic ratio. Anyway, what is the abnormality in lungs? Okay, this is a chocolate question. I can't give you chocolate, I am so far, but this is a credit question. Anybody can answer. Anybody can, if you diagnose. Okay. Yasser Bhatt is right. Obstructed TAPVC. Very good. What is the another differential diagnosis? Yeah, generally infracardiac TAPVC is commonest. PPH, not very convinced because the lung shadows are abnormal. Hyaline membrane disease, very good. Very good. What is the third diagnosis? Anybody? So, hypoplastic left heart syndrome. So, this X-ray when it comes to an exam, it can be hyaline membrane disease, it can be obstructed type of TAPVC, or it is HLHS. Why? Because there is severe pulmonary venous congestion. So, this pulmonary venous congestion looks like, hyaline membrane disease. So, that's why we can give such a differential diagnosis. What is the clue in this X-ray which tells you that this is not hyaline membrane disease and this is cardiac pulmonary venous congestion? What is the clue? Dr. Bhatt, Dr. Mahendra, anybody please? Type something. I don't like, no aerobronchogram, not very clear cut. Okay, guys, there is a right-sided pleural effusion which is of, mild in nature. You can see the blunting of costophrenic angle. You can see here also there is some effusion. So, When it is associated with pleural effusion, it has to be cardiac. Okay, this X-ray findings. Can anyone say the diagnosis? I understand that the lungs are not that clear. Okay, any friends, remember, I will give you a clue. In my first slide, I have told you guys that look here, look there, and look everywhere. So please look everywhere and tell me what is the abnormal finding over here. Okay, I will tell you. Look in the abdomen below the diaphragm. What are you seeing? Type. I don't like to see this empty chat box. Suddenly people stopped typing. Midline lever, boss, can't you see what is this structure? What is this? Anybody? Now I can. You guys are seeing my cursor? Yes or no? Please type. Yes, you guys are seeing my cursor, right? So what is this? What is this? Okay, it's okay. So Dr. Sudipta started typing again. Good. Coil. So it's coil. Basically, this patient had a liver hemangioma and underwent coil closure. So remember, look here, look there, and look everywhere is the motto. Okay, this is diagnosis quite obvious. Fastest finger first. What is the diagnosis? Okay, Dr. Mahendra Singh and Dr. Sudipta typed together scimitar, and you can see this. This vertical shadow is of which structure? Can you name? Nobody? Those who have written scimitar must know. No, not true, Dr. Mahendra, not a right answer. It is actually right-sided descending vertical vein in which at various angles right-sided pulmonary vein joins. Correct. So actually it is this shadow is of a right-sided vertical vein. Okay. And though it's not very clear, but there is a relative hyperinflation of the left lung. Remember, the scimitar is associated with pulmonary abnormalities as well. Like, can anybody tell? Yeah, it's emphysema. What kind of bronchial abnormality? There can be bronchial stenosis. There can be what kind of lung abnormality? Anybody can type pulmonary hypoplasia, right? Dr. Yasser Bhatt, everybody is right. Sequestration is also right answer. So these are the associated abnormalities. Okay, what is this chest X-ray finding? What about the heart? Cardiomegaly, yes. Pulmonary plethora is there or not? Yes or no? Yes, at least central branch PAs are dilated. Prominent NPA. Correct. Apex type, not very clear. Maybe I can still say maybe LV type of apex. The only thing is that, see, this is not very classical, but in this case of truncus, what you see is that relative high takeoff of branch pulmonary arteries. So this is the LPA and this is the RPA shadow. As compared to usual location, RPA here and LPA somewhere here, this is slightly higher up. Obviously, it's not, it is a soft sign, but just for your knowledge, high takeoff of branch pulmonary arteries is seen in chest extravert truncus arteriosus. So, I want diagnosis in this case. Again, chocolate question. Nobody is typing. If I will tell you one clue, no, everybody will type. No, Eisenmenger is a wrong answer. If I will tell you one clue, everybody will type. So look for that clue. Guys, remember A, B, C, D, T of chest X-ray. Airway, bones, cardiac, diaphragm and thymus. So you have to look for bones also. So Yasser Bhatt found it right. Rib notching. So what is the diagnosis? Coarctation of So Dr. Yasser, can you type what is the reason of this rib notching? Or anybody else? Yasser is not typing. Yeah, correct. So Dr. Yasser, you are right. Dilate. It's basically collaterals which is giving rise to rib notching. And again, at what age we see such kind of X-ray findings in coarctation? Do we see this in newborn, infants? Yes or no? Yes, correct. After 10 years. Fine. Maybe even if you say 8 years, it's okay. But it takes a couple of years to develop. What is another abnormal sign in this X-ray? Suggestive of coarctation. Three sign. What do you mean by three sign, Dr. Mahendra? How three sign is produced? This is pre-coarctation segment, this is coarctation segment, and then post-coarctation segment. Correct. Pre and post dilatation. Right. What is this? Okay, ductal aneurysm is the right answer. Any other differential? See, you have to keep various possibilities in the mind. So it can be, this can be ductal aneurysm, it can be aortic aneurysm, it can be pulmonary AV malformation, it can be mass in the lung or mediastinum. This mass can be a fungal bole, especially in the case of immunodeficiency syndrome. Okay, so diagnosis or finding, you can say finding, it's not a problem. Correct. Situs solitus dextrocardia is the right answer. If anybody says mesocardia, that also looks okay because it's not very classical, but fine, both answers are acceptable. So it was a case of isolated dextrocardia where there was a visceral situs solitus. Sorry. Diagnosis. Dr. Mahendra, Dr. Bhatt. Situs inversus, correct. So, situs inversus with dextrocardia. What is this? Come on, everybody should know this. What is this? What is this? Correct. Dr. Sudipta, everybody is right. Everybody is guessing is right. Pacemaker. But again, you have to be very specific. Whenever cardiologist puts pacemaker in the cath lab, it is known as endocardial pacemaker. Just 1 second. Actually, you can see the pacemaker, which is endocardial pacemaker, and which has 2 leads, one atrial and one ventricular. So it is a dual chamber endocardial pacemaker. So answer should be like this: dual chamber endocardial pacemaker. Okay, ECGs. So X-rays, everybody participated. At least 3-4 of them have participated actively. And now ECGs. What is the rhythm? Sinus rhythm is the right answer. What is the rhythm? Kavita? So, first degree heart block or first degree AV block is the right answer. And I have been told that there are 8 to 9 participants. So why only 3-4 are participating? Others, Dr. Sudipta, Yasser Bhatt, Mahinder Singh, these 3-4 people are participating, but others are not. All of you should participate. This is not exam, so it will be more lively. So PR is fixed and longer than 0.2 seconds. What is the diagnosis? Yankee bag, right. Dr. Yasser Bhatt is right. Second degree AV block type, Mobitz type 1, also known as Yankee bag. What is the rhythm? No, it's not complete AV block, Sudipta. 2:1, right. Mahendra is right. It is 2:1 AV block. So second degree AV block type 2, Mobitz type 2, 2:1 AV block. Remember one thing, there is a all or none phenomenon. Either P is conducted or P is blocked. What is the diagnosis? Very easy. You have already seen it. It's not Yankee bag. You have already seen it, I told you. Yeah, when interval is prolonged, it is nothing but first degree AV block. Yeah, Dr. Sudipta is right. What is this? May take little more time, slightly. So it's idioventricular rhythm or ventricular escape rhythm where you are not seeing P waves before broader QRS complexes. So as we have two types of escape rhythm, can anybody type what are the two types of escape rhythm? No. Okay, answer this. This is the second ECG. So whenever it comes to ECG, oh, correct. Yes, Bert is right. Junctional escape rhythm. So there are two, yes, and obviously bradycardia, slow junctional. So there are two types of escape rhythm. One is junctional escape rhythm, which this ECG, and previous ECG, ventricular escape rhythm, which was, in the previous ECG. So these are the two types of escape rhythm. What is this? Take your time. Chocolate question. And whenever it comes to ECG, people have become slow. So I suggest everybody to go through ECGs lying next to patients' bedside every day. Every day. You should keep seeing ECGs and keep discussing among yourselves. Okay. Should I give you a clue or you want more time? Please type. Told T waves. Dr. Mahendra is right. What is the common reason? Told T waves. Hyperkalemia, right? Tall, narrow and symmetric T waves. What is this? Slightly difficult one, but you guys might have heard of it. Wow, excellent. Dr. Sudipta, very nice. Congratulations. Brugada Syndrome. So RBBB in V1 to V3 with convex ST elevation. For those who want to see it again, I'm going back. You can see V1, V2, slightly in V3, you can see convex ST elevation, Brugada. So here, what is the diagnosis? It's easy. Nobody's typing. Let me give you a clue. What is happening to RR interval? Sinus arrhythmia. It can be sinus arrhythmia, but the only thing is that the irregularity of RR interval, what you are observing, is so uniform, which is not the case in sinus arrhythmia. So this is not sinus arrhythmia. Yes, Dr. Yasser Bhatt is right. It's atrial premature contraction. I want to go back and to show you, all of you. See, this PQRST, okay, then at a regular interval again same. But here there is a premature P wave which is followed by QRS complex. Again, these are regular, again premature. Okay? Even it is a kind of, after 1 and 2 beat, again premature. Again 1 and 2 beat, premature. 1 and 2 beat, premature. So atrial bigeminy. Or sorry, trigeminy, not bigeminy. Every third is abnormal. What is this? Anybody? No. Yes. Others. Where do we know? Nobody? Okay. So it is a case of SVT. Yes, you can say SVT, but the detailed diagnosis is a case of atrial flutter with variable AV conduction. You can see here, this is all 1:1 conductions. See, 1 peak, then QRS, 1:1, 1:1. Here you can see 2 peak. Okay? Again 1:1. Again you can see 1, 2, and 3 P waves followed by QRS. These all are 1:1. Okay? So you can see classical flutter waves here. Flutter waves. So it is an atrial flutter with variable AV block. Here there are 3 A waves and then QRS. So 3:1. Here 1:1. Atrial flutter with variable AV block. Sawtooth waves. Okay, diagnosis. Come on, this is easy. We take, but what is the specific type? Correct. Dr. Sudipta found it, right? Torsade de pointis. Twisting around the point, and that's why the terminology torsade de pointis. So, what is the treatment, Dr. Sudipta? Treatment of torsades. You can give shock, but before that, give magnesium is the treatment. What is the diagnosis? So only 2-3 more we'll take, and then probably we may wind up. So all of you can see digoxin effect, very classical mustache of an individual. You can see inverted tick mark sign. So this is a Digitalis effect. It is easy. Very easy. RBBB equals. Commonly seen in which kind of patients in your day-to-day practice? A is D, correct. What is another? Very common. Post ICR. Okay. What is the diagnosis? Swanky baking. What is the diagnosis? SVT, correct. What is the type? Can you say? Correct. Looks like ABRT. You can see this is the retrograde P, which is falling. This is retrograde P. See retrograde P, retrograde P. All this retrograde P, which is falling after every QRS complex, immediately after QRS complex. So narrow complex regular retrograde P waves. Okay. What is the diagnosis? Very easy. Nobody? It's VTech. What is this? Probably we'll skip this. You can see QT prolonged. What is the diagnosis? Any abnormality, yes or no? Is not. We'll skip this. What is the diagnosis here? Very classical. Okay, this is one syndrome. Oh, correct. Mahendra is right. WPW syndrome. Wolff-Parkinson-White syndrome. Short PR interval, prolonged QRS, slurred waves, delta waves. This we have already seen it. We all know the types of heart block. Till the diagnosis. Yes, there is AV block, complete AV dissociation. Okay. Even if you say complete AV dissociation is fine. This ECG was particularly taken at faster speed, 50 centimeter per second. Actually, this was jet. Jet. What is the hallmark of junctional ectopic tachycardia? Is complete AV dissociation is the hallmark of junctional ectopic tachycardia. Always remember. Easy. See these two waves, see these waves, see again these two, again these waves, then these two. Correct, SVT you can say intermittent SVT. So, in automatic type of SVT, this phenomenon can happen. Okay, so I think we can wind up. I just want to ask one or two questions. Dr. Yasser Bhatt, you are from which institute? Dr. Mahendra, you are from which institute? Can you type? Apollo Delhi, Mahendra. Escort Delhi, Yasser Bhatt. Then I think Dr. Sudipta was also answering. He or she, I don't know, has left the meeting, I think, in between. Anyway, you guys really participated in this quiz very well. Before winding up, again, I just want to summarize 3-4 important points. For X-ray, A, B, C, D, T, airway, bones, cardia, diaphragm, and thymus. Look here, look there, and look everywhere. Always focus things below the diaphragm also. And it can be classical, it can be non-classical. And in ECGs, you know, you have to read it thoroughly, and each wave pattern you have to pay attention, and that's why most of the time you will come to a diagnosis. Some of you have not participated in spite of attending a lecture. I would encourage students to participate always, even if they are wrong. There is no harm, but you know, it increases the confidence building during such exercise, and that's why during your exam confidence increases. Thank you, everybody. It was pleasure interacting with all of you. Thank you so much.